There's a pattern I keep seeing in patients over 50, and it took me years to understand why it kept repeating itself. They come in for something routine, blood pressure check, a follow-up on cholesterol, sometimes just a physical they delayed for 2 years, and somewhere in the middle of the visit, almost by accident, they mention it. Their feet have been bothering them, a little numbness, some swelling they assumed was the heat, a toe that's been changing color for a while. They show me, and what I find has nothing to do with their feet. That's the part nobody prepares you for. Your feet are not just feet, they're a surface layer, a visible readout for things happening deep inside your body that aren't producing any other symptoms yet. Circulatory compromise, neuropathic damage, organ stress, sometimes early metabolic collapse. And because your feet are far from your core, far from your chest and your gut and your brain, they show signs of systemic deterioration before anywhere else does. Doctors have known this for a long time. Most patients haven't. I've watched people walk around, sometimes for years, with signs on their feet that were direct evidence of serious disease. They didn't know. Their feet looked fine enough, a little rough, a little puffy. Nothing that seemed worth a phone call. But fine enough and clinically normal are two very different things. And in those gaps, disease progresses. So what I want to do here is walk you through 7 specific changes, not vague discomforts, not your feet feel tired, specific, observable physical changes that clinical experience has taught me to treat as red flags. Because once you understand what they actually represent, you won't be able to unsee them. The first one is hair loss on the lower leg and the top of the foot. Most people don't connect their foot hair to their cardiovascular system. It seems disconnected, but hair follicles are extraordinarily sensitive to blood supply. They need a continuous, well-pressurized delivery of oxygen and nutrients to sustain themselves, more than you'd think for something so small. When circulation begins to deteriorate, and in peripheral arterial disease, it deteriorates quietly for years before any other symptom appears. The follicles are among the first structures to starve. What happens is incremental. The hair thins, then it stops regrowing after it falls out. Then the skin on the same area starts to look slightly different, a little shinier, a little tighter, a little more pale under pressure. Most people attribute it to aging. Some attribute it to dry skin. Some don't even notice because they've stopped looking closely at that part of their body, and the arterial narrowing continues. Peripheral arterial disease affects a significant portion of people over 60, and the vast majority of them have no idea. The classic symptom, calf pain when walking, called claudication, often doesn't show up until the disease is already moderately advanced. Hair loss on the foot and lower leg is one of the earliest external signs available. It doesn't require a scan. It doesn't require a lab test. It requires looking. If you're over 50 and the hair on your lower shins and feet is noticeably sparse, especially if it's become sparse recently, or if it's sparse on one side more than the other, that asymmetry matters. Asymmetry in peripheral circulation is a clinical finding. It tells you something about where the arterial compromise is happening. I want you to think about something for a moment. When you last looked carefully at your lower legs, not glanced, looked, most people can't remember. The second sign is persistent puffiness in one foot or ankle that doesn't fully resolve overnight. Bilateral swelling, both ankles, both feet, is often benign. Gravity, prolonged sitting, heat, medication side effects. But unilateral swelling, one side consistently more swollen than the other, is something different. The most serious reason for persistent one-sided lower leg swelling is deep vein thrombosis, a clot forming inside one of the deep veins of the calf or thigh, obstructing venous return, causing fluid to back up. DVT is not rare in the population over 50. Risk increases with age, with immobility, with dehydration, with post-surgical recovery, with any inflammatory condition. It can be completely silent, except for the swelling, and sometimes not even that. What concerns me clinically is when someone describes waking up and noticing one calf or foot consistently looks larger than the other. Not painful. Many DVTs cause no significant pain, which is part of what makes them dangerous. The clot can propagate silently upward. Fragments can break off and travel to the lungs, a pulmonary embolism, and that event is where things become acutely life-threatening. There's a reflexive tendency to assume the swelling is lymphatic, or that it's just the way your body is. Some people carry mild asymmetry their whole lives, but asymmetric swelling that is new, that has developed over weeks or months in someone over 50, is not something you explain away, it's something you image. An ultrasound of the deep venous system takes about 20 minutes and tells you definitively whether there's a clot. I've seen patients describe months of unilateral swelling that they mentioned to a family member who said, probably just fluid. By the time it came to my attention, the DVT had been there long enough to create significant post-thrombotic syndrome, chronic damage to the venous valves that causes years of swelling, pain, and skin changes afterward. The window for clean anticoagulation was gone. One side, more than the other. New onset after 50. That warrants a call. The third sign is a change in nail color or texture that isn't explained by trauma. Nails are keratin, and keratin is produced by a structure, the nail matrix, that depends entirely on local blood supply and systemic nutrient delivery. Changes in nail color, thickness, curvature, and texture are not cosmetic events. They're metabolic events. The most overlooked nail change in my clinical experience is the development of a yellowed, thickened, slow-growing nail that people assume is fungal. And sometimes it is fungal, but yellow, thick, crumbling nails are also a presentation of lymphatic dysfunction, and the two look almost identical to the untrained eye. Lymphedema affecting the lower extremities can present with nail changes years before any obvious limb swelling. The nails change first because the nail bed is a vascularized structure and lymphatic stasis affects its architecture. Separately, dark streaks running vertically through a nail, what's called a subungual linear pigmentation, are usually benign in people with darker skin tones and can represent melanocytic activity. But in someone with lighter skin, a dark vertical line under a nail that is new, that is widening, that involves the skin around the nail fold, what clinicians call Hutchinson's sign, is a potential indicator of subungual melanoma. One of the most diagnosed too late skin cancers, precisely because people see it as a nail injury and wait. Blue or purple nailing, cyanotic discoloration visible through the nail, means there isn't enough oxygenated blood reaching the nail bed. Causes range from severe Raynaud's phenomenon to cardiac output compromise to severe peripheral vascular disease. This is not a sign you watch for a few more weeks. Spoon nails, concave, upward curved nails, are classically associated with iron deficiency anemia and sometimes with hemochromatosis, a condition of iron overload that quietly damages the liver and joints for years before diagnosis. Nail findings of this kind don't occur in isolation. They occur in the context of a body that is biochemically off, and they are sometimes the only external sign. The fourth sign is a wound, cut, or blister on the foot that heals unusually slowly. Normal wound healing in healthy tissue follows a predictable arc. The inflammatory phase, the proliferative phase, tissue remodeling. From a minor cut to complete healing in days to a couple of weeks, depending on depth and location. Impaired wound healing on the feet is one of the clinical presentations of advanced diabetes that I find most alarming, not because it's rare, but because people with prediabetes and even frank type 2 diabetes are often undiagnosed for years. The impaired healing reflects two converging problems: reduced blood flow to the peripheral tissues from diabetic vascular disease, and peripheral neuropathy that removes the pain sensation that would otherwise make you protective of a wound. Someone without peripheral neuropathy feels a blister forming, feels it worsening, and does something about it. Someone with peripheral neuropathy may not feel it at all. They may walk on a wound for days without awareness. By the time they see it, the wound is deeper than expected, potentially infected, potentially reaching the subcutaneous tissue. Diabetic foot ulcers are the leading cause of non-traumatic lower limb amputations in the United States. The majority begin as small wounds, blisters, cuts, pressure points from ill-fitting shoes that don't heal and progressively worsen. And the patients who come in with them almost universally say some version of the same thing. They didn't think it was serious. It wasn't hurting much. Slow healing doesn't just signal diabetes. It can also indicate arterial insufficiency, nutritional deficiencies, particularly zinc and vitamin C, certain autoimmune conditions, or the effects of prolonged corticosteroid use. But in the context of someone over 50 who has any metabolic risk factors, a wound on the foot that isn't progressing normally after 10 days is worth more than watchful waiting. The fifth sign is cramping in the arch of the foot or the calf at night that wakes you up. Nocturnal leg cramps, sudden painful involuntary muscle contractions that strike in the middle of sleep, are common enough that people rarely report them to physicians. They're considered part of aging, an annoyance, something you deal with by stretching and waiting it out. Sometimes that's accurate. Benign nocturnal cramps exist. Dehydration and electrolyte shifts from medications, particularly diuretics, which are prescribed to a large number of people over 50, cause cramps through simple mechanisms. Reduced mobility and prolonged positions during sleep are contributing factors. But there are two clinical presentations that concern me significantly more. The first is cramps that occur during or immediately after mild exertion, walking a short distance, climbing stairs, and resolve quickly with rest. This pattern, pain on exertion, relief with rest, is the signature of peripheral arterial disease. The muscle isn't getting enough blood under demand. It cramps, you stop. The blood demand drops. The cramp resolves. Most people don't connect the pattern because the events feel separate. The cramp during the walk, the relief afterward. They adapt by walking less. The arterial disease progresses. The second presentation that warrants attention is cramps associated with restless leg syndrome that has escalated in frequency and intensity. RLS is far more than a sleep nuisance. It has associations with iron deficiency, kidney disease, and peripheral neuropathy. A patient with new onset or worsening RLS after 50 should have their ferritin level checked and their renal function assessed. These aren't tests that require a specialist. They're basic blood work. But they're often not ordered because the symptom sounds minor. The sixth sign is a change in foot shape, specifically a loss of arch height or a toe deformity that has developed over time. This one is more structural, but the clinical implications are real. Progressive flat foot in an adult, not someone who is always flat-footed, but someone whose arch has visibly collapsed over a period of years, is most commonly due to posterior tibial tendon dysfunction. The posterior tibial tendon is the primary structural support for the medial arch. When it fails, the arch collapses, the foot pronates excessively, and the alignment of the entire lower extremity changes. Knee pain, hip pain, and lower back pain that seem to have no clear cause often traced directly to arch collapse that started in the foot and was never addressed. But there's a less commonly discussed cause of foot deformity in the older population, and that's Charcot foot, a severe complication of peripheral neuropathy, most commonly diabetic, in which the bones of the foot begin to fracture and dislocate in the setting of impaired sensation, because the person can't feel the pain that normally accompanies fractures. They continue walking on the foot. The structural damage accumulates. The foot takes on a characteristic rocker bottom deformity. By the time this is identified, significant permanent damage is often present. Hammer toes, flexion contractures of the toes, are extraordinarily common and often dismissed as merely inconvenient. They create abnormal pressure points on the tops of the toes and at the tips. In someone with normal sensation and good circulation, this is a mechanical problem. In someone with peripheral neuropathy, those same pressure points become wound sites that don't heal. Structural changes to the foot are not cosmetic, they're biomechanical, and in the right systemic context, they're neurological. The seventh sign is skin that is unusually cold, pale, or mottled on one foot or portion of the foot. Skin temperature is a direct readout of blood flow. Under normal conditions, both feet should be roughly similar in temperature, not identical, but not dramatically different. When one foot is consistently colder than the other, there is less blood reaching it. That's not an interpretation, that's the mechanism. Acute arterial occlusion, a sudden blockage of a major artery to the lower extremity, is a medical emergency. The classic presentation taught in every emergency medicine program, the 5 Ps, pain, pallor, pulselessness, paresthesia, paralysis. A foot that goes suddenly pale, cold, painful, and numb is an emergency presentation that requires revascularization within hours before permanent tissue damage sets in. But that's the acute dramatic version. The subtler version, the one people live with, is chronic arterial insufficiency, presenting as a chronically cool, slightly pale foot with reduced capillary refill, maybe some mottled, patchy discoloration at rest. The skin may look slightly bluish when the leg is elevated and reddish when dependent. This color change with position, what clinicians call dependent rubor, is a classic sign of severe peripheral arterial disease. The blood is barely getting there at all. Gravity is doing some of the work that the arteries should be doing. Modeling that irregular net-like purple-reddish discoloration of the skin called livedo reticularis has a wide differential. In younger people, it's often benign and cold reactive. In older people with cardiovascular risk factors, it can represent cholesterol embolization, autoimmune vascular disease, or antiphospholipid syndrome, a clotting disorder that dramatically increases the risk of stroke and deep vein thrombosis. When I see livedo reticularis in a patient over 50 who hasn't had it their whole life, I start asking questions, not about their feet, about their cardiovascular history, their autoimmune history, their medication list. This is the central point, and it's the one I want you to carry out of here. The foot doesn't have the diseases, the foot shows them. When you look at changes in your feet, persistent, unexplained changes, progressive changes, asymmetric changes, changes that started after 50 and don't fit any obvious explanation, you are looking at the external surface of an internal process. The process may be circulatory, it may be metabolic, it may be neurological, it may be hematological. The disease isn't in your feet, it's using your feet as a billboard. What I've seen clinically is that the people who catch these diseases early are not the people who have better doctors. They're the people who pay attention to their own bodies closely enough to notice when something changes. Not dramatically changes, just changes. And then brings that change to a physician without waiting for it to get worse. If you're subscribing to this channel and you haven't subscribed yet, stay here because what we're doing is building a different kind of health literacy. Not just understanding disease names and statistics. understanding your body as a system that communicates, that gives signals, that produces findable evidence of what's happening inside it before crisis arrives. That's what I find valuable to teach, and that's what brings people back here. If any of what I just described resonates, any of those 7 changes, look at both feet right now, today, not next week. Compare them. Look at the color, the temperature difference if you can detect it, the hair distribution, the nail texture, the shape, the presence or absence of swelling. Take a photograph. Look at it again in 30 days. Change over time is evidence. Static observation is almost useless. Tell me in the comments, and I do read them, which of these 7 was the one you hadn't connected before, the one that surprised you. I want to know because it shapes what I cover next. One more thing. If you showed this to someone over 50 who hasn't been paying attention to this kind of thing, someone who dismisses symptoms, who delays checkups, who doesn't like talking about bodies, that might be the most useful thing you do with this video. Your feet have been trying to tell you something. You just needed to know how to read them.